continuation of our previous class. So we discussed about the angina, we discussed about the unstable angina, myocardial infarction, ST elevation, non-ST elevation, etc. Now we move on to the management part. This is very, very important. So now the management of the angina, a careful assessment of the likely extent and severity of the arterial disease, identify and control the significant risk factors. This is the very, very important in all the IHD population. So you have the 5 vascular risk factors, major vascular risk factors. You have the many minor vascular risk factors and also the emerging vascular risk factors. Diabetes, hypertension, dyslipidemia, obesity or physical inactivity, smoking. Okay, fine. The use of the methods to control the symptoms. See, in all angina pectoris people, so finally, ultimately asymptomatic. So they come to you with a chest pain. So control the symptoms, either the chest pain or the breathlessness or the palpitations or the syncope, etc. These are all the vascular symptoms. Vascular symptoms is not only always the chest pain. So chest pain is maybe in 30 to 40% of the population. Remaining people, they may present like syncope because of the severe aortic stenosis. Some people they present with breathlessness. Some people they present with palpitations, maybe ventricular fibrillations, atrial fibrillation, tachyarrhythmias, etc. Identify high-risk patients and application of the treatment to improve the life expectancy. So identify the high-risk patients. Who are the high-risk patients? So these are all the people what we have told so far. The risk factors, they are at the high-risk patient. Suppose a patient's hyper beta lipoproteinemia is there, hyper uricemia is there, or your microalbuminuria is there. So he is a non-smoker, a non-alcoholic, non-obese, but still the vascular risk factors are there. You have to check for the asymptomatic ischemic heart disease in those individuals. So this is the management part. So this shows you very clearly stable angina on effort. Okay. So intercurrent illness are unsuitable for the revascularizations. Suppose the patient is also having several comorbidities, is not fit for the revascularization. So what to do? So obviously what to do when the fellow is not fit for your PTCA or angiogram? Obviously medical management. Okay, so that is a medical management. Suppose if you have done the stress test, so stress test is negative, so again a medical therapy. Suppose it is the positive, is of low risk or the high risk. So the low risk you need not subject for your CAG, but again go for the lifestyle changes and the medical therapy. Suppose the high risk individual, the symptoms are very high, the risk factors are very high, TMT is positive, so then go for the CAG, coronary angiogram. So the coronary angiogram shows you 3 types of the diseases. One is SVD, single vessel disease, DVD, double vessel disease, TVD, triple vessel disease. Suppose the single or the 2 vessel disease, so definitely you can go for the PTCA, or if the disease is very diffuse, then go for the CABG, even it is a single vessel disease or a double vessel disease. In the triple vessel disease, always we will go for the CABG. So that's how we have to manage the angina pectoris individuals. So whenever you see an angina fellow, so you have the 2 or 3 options are there. One is the medical management, the second one is the PTCA, the third one is the CABG. So medical management, this is the one. Promote the vasodilatation by using the nitrates, by using the calcium channel blockers like the diltiazem. Reduce the recurrent triggering. So give the bed rest, BP control, beta blockers, so they reduce the heart rate. Prevent the thrombosis by using your aspirin or clopidogrel, etc. antiplatelet agents, antithrombin therapy, coagulation methods. Promote the healing by means of your vasculoprotective drugs like ACE inhibitors or ARBs. Treat and prevent the complications of the acute ischemia or the necrotic myocardium by using the beta blockers and the antiarrhythmic drugs, because arrhythmias are very common complication of your acute myocardial infarction. Open the artery if they are totally occluded by means of your streptokinase or your PTCA. So this is the different ways of using different drugs in the management of the ischemic heart disease. So to promote vasodilatation, to reduce the recurrent triggerings, to prevent the thrombosis, to treat the complications, promote the healing, and finally, if the artery is blocked, so you can open the artery with your either with your medical thrombolytic therapy or with your CAG and PTC and CABG. Advice to the patient with a stable angina. What are the lifestyle modifications? So first and foremost is the smoking. So smoking is always dangerous for the vessels, whether it is a cigar or BD or cigarette or pan parak, gutka, etc. So all are dangerous. So smoking in any way has to be abandoned. Aim at the ideal body weight. So you know the ideal body weight, ideal BMI for us is the 23, not the 25, unlike the Westerns. So we are having the more abdominal adiposity. For a given BMI, we are having the more adipose tissue, more visceral fat, and more atherosclerotic situations or incidents will occur very high once the BMI is more than the 23. So our BMI is the 23. And more than the BMI, waist hip ratio is very important for Indians. Waist circumference less than 90 in the males, waist circumference less than 80 in females is the ideal one. So waist circumference is much more better indicator than the BMI for the Indian population. Take the regular exercise. It's a very important. So you have the aerobic exercises, resistance exercises. So aerobic exercises like simple walking or treadmill or the jogging. So they are all very, very good. Exercise up to but not beyond the point of the chest pain is beneficial and may promote the collateral vessels. Why the exercise? Exercise means you are reducing the blood sugar, you are reducing the blood pressure, you are reducing the cholesterols, you are giving the cardiac health, you are giving the bony health, and you are also giving, in some individuals, they may reduce the body weight also with a good exercise. So these are all promotes the vessels, vascular things. But most important with exercise and the heart is it promotes the collateral vessels. See, when the one artery is blocked, so the collaterals will open, and then through the collaterals, that part of the heart, that part of the myocardium will be supplied. So to improve the collateral supply, so different exercise will help a lot. You avoid severe unaccustomed exercise and vigorous exercises after a heavy meal or in very cold weather. So they may lead to vasoconstriction and they may increase the chances of your cardiac events. Take sublingual nitrate before undertaking the exertion that may induce the angina. So when the fellow is subjected for the exercises or for the walking for the prolonged periods, so definitely these sublingual nitrates will help them to reduce the anginal attacks. But don't avoid exercise, heavy exercises in all our ischemic heart disease population. So while doing the exercise also, you know that rule. So the maximum heart rate rule. So how you calculate the maximum heart rate? 220 minus your age. So 220 minus the age of that particular person is the maximum heart rate. And don't achieve that maximum heart rate. Just achieve 70 to 80% of the maximum heart rate. Suppose your age is say 30 years. So 220 minus 30 is 190. So don't achieve the 190 heart rate while doing the exercise. Maybe 70 to 75% is applicable. So maybe 140 or 150, not beyond the 150 of your heart rate. For me, it may be 130 or 125. So that is very, very important. So if you cross that maximum heart rate, so definitely these people will land up with arrhythmias, will land up with sudden cardiac deaths, etc. So the medical management, these are very, very important drugs. Antiplatelet therapy, aspirin, maybe the low dose aspirin. So aspirin is available in India in the form of 75 mg and the 150 mg. Whereas in the US, you can also have the baby aspirin, maybe 33 milligrams of the aspirin. So along with the aspirin, we also use the clopidogrel. So the clopidogrel is about 75 milligrams. So usually in the first 6 months or the first 1 year, we use the both. So the book says for 6 months, but practically we use for 1 year the double platelet agents. So both the aspirin and the clopidogrel. So that is 75 plus 75 is available, or 75 of aspirin and 150 of the clopidogrel is available, or 150 of the clopidogrel and 75 of the aspirin is also available. So we give 2 tablets a day. That means 150 milligrams of the aspirin and 150 milligrams of the clopidogrel for a period of about 6 to 1 year, and after that you can choose to a single antiplatelet agent. Suppose if the patient is not having any gastritis, non-smoker, so you prefer to continue the aspirin. Suppose if the patient is a smoker or chances of having the gastritis, etc., so then we prefer the clopidogrel in the place of the aspirin. Anti-anginal drug treatments, you have the nitrates. So you have the dinitrate, you have the trinitrate, you have the mononitrates, you have the beta blockers. Beta blockers may be metoprolol or bisoprolol, and calcium antagonists. You have the two types of the calcium antagonists: dipyridine, pyridone antagonists. So like your verapamil and the diltiazem, or other drugs like your amlodipine and the cilindipine. As far as the ischemic heart disease is concerned, we prefer diltiazem, non-dihydropyridine calcium channel blockers. So the nitrates are the very important drugs to be used here. So what is the mechanism of the action? They act directly on the vascular smooth muscle to produce a venous and arteriolar dilatation. They don't act on the arterioles. So they act on the veins and the arterioles. Beneficial effects in the angina are due to the reduction in the myocardial oxygen demand. They reduce the preload and the afterload. They increase in the myocardial oxygen supply because of the coronary vasodilatation. So there will be the venous dilatation, there will be the arteriolar dilatation, there will be the coronary vasodilatation. So that is how the nitrates are very much useful to improve your oxygen supply and also to reduce the oxygen demand. The side effects are very common with the nitrates. The most common side effect is the headache, and some people may have the hypotension. Mostly asymptomatic hypertension. Some people may have the symptomatic hypertension also, and rarely the syncope. These are the duration of the action of some nitrate preparations. Sublingual GTN, the peak action is about 4 to 8 minutes. The duration of the action is 10 to 30 minutes. So this we give. So always give these things. Okay. Buccal GTN is also available, and the transdermal GTN is also available. So we advise them, those people who are on prolonged exercise, those people who are working in the cold weathers like in the Kashmir or in other places. So these people, we advise the buccal GTN and the transdermal GTN. It's not widely available, but the sublingual GTN is always available there. And as oral form, we use isosorbate dinitrate and isosorbate mononitrate, maybe 2.6 milligrams, maybe BD or the TAD. In the same way, monotrate 10 mg or 20 mg or 60 mg. So they are also available. So this is the very important practical point. Continuous nitrate therapy causes the pharmacological tolerance. So avoid it by using a regimen that includes a nitrate-free period of 6 to 8 hours every day. Okay, this is very important. Should not use the nitrates stands in the blood for about 24 hours. So there should be a nitrate-free period of about 6 to 8 hours. Otherwise, these people will get the tolerance to these nitrates. Once daily proprietary preparations with a built-in nitrate-free period are available. So right now they are all available. So we use maybe OD or the BD. So the beta blockers are the very, very important drugs in the IHD. That the compelling indication to use the beta blockers is the ischemic heart disease. Whether the angina pectoris or unstable angina or myocardial infarction or post-PTCA or post-CABG, whenever you see in a cardiology case, in the all the cases will have some element of your beta blocker. Maybe metoprolol 12.5 mg or 25 mg or 50 mg, 75 mg, 100 mg. In the same way, the bisoprolol 1.25 mg, 2.5 mg, 5 mg or 10 mg. So the actions, they lower the myocardial oxygen demand by reducing the heart rate. So the bradycardia is the one important contraindication to use the beta blockers. So whenever the fellow is on the beta blocker therapy, in the follow-ups, so you should concentrate on the heart rate. When the heart rate is less than the 50, so better to stop it. Between the 50 and 60 also you can use it with the reduced dosages, even though the book says that bradycardia means less than the 60. But practically, we can give the beta blockers till the heart rate is up to 50. So they reduce the heart rate. they reduce the blood pressure and also the myocardial contractility. What are the adverse effects of the beta blockers? So some of the beta blockers may increases the blood sugars, so dysglycemia. Some of the beta blockers will cause dyslipidemia. Some of the beta blockers will increase your uric acid, hyperuricemia, and so they exacerbate the symptoms of the peripheral vascular disease. In that way, beta blockers are contraindicated in peripheral vascular disease, PVD. They provoke the bronchospasm in patients with obstructive airway disease. So that is the reason we don't use the beta blockers in COPD, bronchial asthma, etc. Routine beta blockers. But cardioselective beta blockers you can use in these conditions even though the patient is having IHD or the post-PTC or CABG. See, a lot of the people in India, they are with bronchial asthma, they are with CABG, they are with emphysema. So these people again happens to be a diabetic or an hypertensive. So obviously they are the candidates who get the ischemic heart disease. So after the post ischemic heart disease, definitely have to use the beta blockers to reduce the heart rate, to reduce the myocardial contractility, to reduce the blood pressure. So in such situations, you can use the cardioselective beta blockers like bisoprolol or metoprolol or carvedilol or the nebuvolol. But don't use the atenolol or propranolol in these cases. Non-selective beta blockers, they aggravate the coronary vasospasm by blocking the coronary artery beta 2 adrenoceptors. So we don't use them. Once daily, cardioselective preparations are advisable. So I don't prefer the atenolol here, but slow release metoprolol and bisoprolol are very useful here. Should not be withdrawn abruptly. So that is again a good practical point. So whenever a fellow is on the beta blocker therapy for prolonged usage of the beta blocker therapy, if you want to change the beta blockers, so be patient. So not to withdraw the beta blocker suddenly because it precipitates the dangerous arrhythmias, worsening the angina or the myocardial infarction. So the beta blocker withdrawal syndrome. So calcium antagonists like diltiazem is useful in angina, inhibit the slow inward current caused by the entry of the extracellular calcium through the cell membrane of the excitable cells, particularly cardiac and the arterial or smooth muscles. They lower the myocardial oxygen demand by reducing the blood pressure and also reducing the myocardial contractility. So even though we say that beta blockers are the compelling indications, we don't use the calcium channel blockers in all the cases of ischemic heart disease. Very, very few, maybe 5 to 10% of the cases. Maybe in the pringimetal angina or maybe the unstable angina, we use these calcium channels. But in a typical angina pectoris, stable angina, or in post-MI or in post-CABG, so we don't use the calcium channel antagonists. So these are the different calcium channel blockers. We have the nifedipine, nicardipine, amlodipine, verapamil, diltiazem. Out of them, diltiazem is the most useful drug. What are the unwanted effects of these calcium channel blockers? Aggravates or precipitates the heart failure. Edema, you all know that edema is a very common side effect of these calcium channel blockers, especially amlodipine and cilindipine. Flushing is also very common with amlodipine. Headache and the dizziness because they are the vasodilators. Potassium channel activators. So the mechanism of the action, arterial and the venous dilatation. Advantage, they do not exhibit the tolerance as seen with the nitrates. Necorondil, 10 to 30 milligrams 12th hourly orally. They are available. Necorondil. So 10 to 30 milligrams 12th hourly orally. So that is something about your angina pectoris. Now we'll move on to the myocardial infarction management. See this picture in 1 hour, 4 hours and the 8 hours. So the necrotic area. So the infarct area. So infarct area is increasing by delaying the time. So the early onset window period is a very, very important in the management of the myocardial infarction. So the lesser the time, so the better the survival. Otherwise, the myocardial tissue will become more and more necrotic and they will present with acute heart failure. They present with arrhythmias. They may present with sudden cardiac deaths also. Why early treatment? Almost a quarter of all cases of the MI death occurs within a few minutes without the medical care. Half the deaths from the MI occur within 24 hours of the onset of the symptoms. 40% of all affected patients die within the first month. So that is the very high mortality disease, myocardial infarction. So most of the cases they die within 1 hour or within a day or within a month, unless you diagnose the properly and you don't care for the patient. Early management. So what is the early management? Provide the facilities for the defibrillation. So all our emergency wards will have a defibrillator and you should know how to use it. Oxygen, IVSS, ECG monitoring, IV analgesia like opiates and the antiemetics. So this is the immediate measures we have to take once the diagnosis is the myocardial infarction. Reperfusion. So give the aspirin, maybe 300 milligrams, not the entry-coated aspirin, but a chewable aspirin. Okay, Disprin. So 300 milligrams. Plus thrombolytic therapy or the primary PCI provided if the facilities are available. Detect and manage the acute complications like arrhythmias, further ischemia, and acute heart failure. So this is the very important. So whenever you see a myocardial infarction, so by taking an ECG, so immediately oxygen supply, ECG monitoring, IV analgesias, maybe antiemetics, then the aspirin loading dose, and then along with the aspirin also you can give the clopidogrel also as a loading dose of 300 milligrams, and you can give the high dose statins, maybe 80 mg of the atorvastatin or 40 mg of the rosuvastatin, or some people they give the 40 mg of the atorvastatin or 20 mg of the rosuvastatin, and then detect and manage the acute complications. So watch for any arrhythmias or the heart failure. So in the acute heart failure is there, then you can give the diuretics and then the arrhythmias, so antiarrhythmic measures. Analgesia to relieve the severe distress, to lower the adrenergic drive, thereby reduce the pulmonary and the systemic vascular resistance and susceptibility to the ventricular arrhythmias. IV opiates, initially morphine, so 10 mg, or diamorphine 5 milligrams, and antiemetics. Aspirin is very, very important, 75 to 300 milligrams, but you can say 300 mg, not 75 mg. Usually we give the 300 mg as a loading dose there. Improves the survival. See, 30% reduction in the mortality on its own. Very cheap drug, but best results. Enhances the effect of the thrombolytic therapy. So whether you are streptokinase or you are primary PTCA, so definitely this aspirin will help you a lot. The first tablet should be given in a soluble or the chewable form, not the entry-coated. Therapy should be continued indefinitely if there are no untoward effects. Then the acute reperfusion. So the thrombolysis and the primary percutaneous coronary interventions. Thrombolysis helps to restore the coronary patency, preserves the left ventricular function and improves the survival. Successful thrombolysis leads to reperfusion with the relief of the pain. Once there is a reperfusion, obviously the patient pain will be subsided. Resolution of the acute ST elevation. So in the repeated ECGs or in the ECG monitoring, so you can see the diminution of your ST elevations. And sometimes the transient arrhythmias may appear, but once the arrhythmias is only atrial fibrillations or ventricular fibrillations, then you can act accordingly. They reduce the hospital mortality of the myocardial infarction by between 25 to 50%. So 30% reduction with your aspirin and with the thrombolytic therapy up to the 80%. So both the aspirin and the thrombolytic therapy will give you nearly 80% response. So the benefit is greatest in those patients who receive the treatment within the first few hours. That is the very important. So here the time is the muscle. Choice of agents is less important than the speed of the treatment. So this coronary thrombolysis, thrombolytic therapy, they restores the coronary patency, preserves the left ventricular function. So still the EF will maintain above 50. Otherwise in the chronic, when the ischemic zone is increasing, when the necrotic zone is increasing, So slowly the EF will come down to 30%, 40%, less than the 50%. So the time means muscle. Minutes means muscle. The sooner the patient is treated, the better the results will be. Any delay will only increase the extent of the myocardial damage, and obviously you are inviting more and more complications like failure or arrhythmias, and then the death is also very common when the treatment is delayed. So what are the thrombolytic drugs? You have the streptokinase, age-old drug. Now even the government is applying this alteplase, also called as the tissue plasminogen activator, tenecteplase and the riteplase. These thrombolytic therapies significantly reduce the short-term mortality in patients with the suspected myocardial infarction. If it is given within the 12 hours of the onset of the symptoms, the ECG shows bundle branch black or the characteristic ST segment elevation, you just give the streptokinase or the alteplase, even though you are in the PHCs or even though you are away from the main hospital. So you can give the aspirin, you can give the clopidogrel, you can give the thrombolytic therapy. No benefit in those who present more than the 12 hours after the onset of the symptoms. Those with a normal ECG or the ST depression, so not of much use when you give this thrombolytic therapies. So streptokinase 1.5 million units in 100 ml of the saline given as an IV infusion over the 1 hour, not as 10 hours or the 8 hours. So give as fast as possible. So within 1 hour, maybe 30 minutes to the 1 hour, you have to give this 1.5 millions of units of your streptokinase in about 100 ml of the saline. Sometimes it causes serious allergic manifestations. They may produce hypotension. Circulating neutralizing antibodies are formed following the treatment, and these antibodies may persist for 5 years or the more. So while giving the streptokinase, so load it in 100 ml of the saline and give it over the 30 minutes to 60 minutes, and then watch for any hypotension or allergic manifestations. So these two are very common side effects of this streptokinase. Alteplase, that is the tissue plasminogen activator, this is not antigenic unlike your streptokinase and rarely causes the hypertension. So hypertension is less, allergic manifestations are less when compared to the streptokinase. So your drug of choice is alteplase. The standard regimen given over the 90 minutes. So the bolus dose of 15 mg followed by 0.75 milligrams. It is genetically engineered drug, more expensive than the streptokinase, not antigenic and rarely causes hypertension. It produces better survival rates than the streptokinase and slightly higher risk of the intracerebral bleed. So thus that bleed risk is there with this alteplase. So when the fellow is blood pressure is very high, any recent history of any gastrointestinal bleed or any history of the hemorrhoids or any past history of the intracerebral hemorrhages or subarachnoid hemorrhages, etc. So better not to use these thrombolytic drugs. Tenecteplase as effective as alteplase in relation to the risk of the major cardiac events including the death and the MI. Intracerebral bleeding risks are very similar. So what are the contraindications to your thrombolytic therapy? So active internal bleeding, previous subarachnoid hemorrhage or intracerebral hemorrhage, uncontrolled hypertension, so accelerated hypertension or hypertensive urgency, hypertensive emergency or malignant hypertension. So we should not use these drugs. And a recent surgery, a recent trauma, high probability of the peptic ulcer, bleeding, and in they are contraindicated. So your ECG shows ST segment elevation. So give the aspirin. ASC means aspirin. So beta blockers, give the metoprolol or the bisoprolol, and antithrombin therapy. So less than the 12 hours and more than the 12 hours. Less than the 12 hours, eligible for the thrombolytic therapy. So go for the thrombolysis. Thrombolytic therapy is contraindicated. So then obviously because of this accelerated hypertension or bleed or peptic ulcer, etc. So primary PCA. More than the 12 hours, if the symptoms are still persisting, then consider for the reperfusion therapy. Otherwise, use the ACE inhibitors or the nitrates, etc. So aspirin or clopidogrel or ACE inhibitors or ARBs and nitrates. So these are the common drugs we prescribe as far as the medical management is concerned. Heparin, subcutaneous heparin. So this also we give it in all these acute myocardial infarction. Okay. Low molecular weight heparins or subcutaneous heparin, maybe 12,500 units twice daily, given in addition to the oral aspirin. Prevent the reinfarction after the successful thrombolysis. Reduce the risk of the thromboembolic complications. Warfarin, if there is a persistent atrial fibrillation or evidence of an extensive anterior infarction. Echo shows the mobile mural thrombus. These patients are at increased risk of systemic thromboembolism. So to avoid that, so you can use this warfarin or the heparin. So in the acute myocardial infarctions, don't go for the oral therapy. So always we give the intravenous. The beta blockers are also available. So I don't think that atenolol is available in IV, but metoprolol is also not. They relieve the pain, they reduce the arrhythmias, avoid in heart failure, heart block, or severe bradycardia. Chronic oral beta blocker therapy improves the long-term survival. So the only drugs which reduces the mortality are the beta blockers. So that is the reason beta blockers are the compelling drugs to be used in all the high HD population and also in tachyarrhythmia population and also in heart failure population. So for cardiology population, cardiology patients, so the beta blockers are very, very useful drugs, except in blocks, except in bradycardias. So nitrates, already told you, IV nitrate, that is our GTN nitroglycerin 0.6 to 1.2 milligrams per hour. Useful for the treatment of the left ventricular failure, relief of the recurrent or the persistent ischemic pain. No evidence of a survival advantage from the routine use of oral nitrate therapy, oral calcium antagonists, or IV magnesium. So you have the survival benefit only with your beta blockers therapy. But no evidence of a survival advantage with your nitrates therapy or with your calcium antagonists. So these are the contraindications to the thrombolytic therapy. Already told you, active internal bleed, arachnoid, subarachnoid, uncontrolled hypertension, etc. So now move on to your coronary angiogram. See the beautiful picture here. First picture and the second picture. A complete occlusion of the proximal right coronary artery. Appearance of the right coronary artery following the successful thrombolytic therapy. So immediate or the primary angioplasty without the thrombolysis of the infarct related coronary artery. That's what we are doing nowadays, because every place we are having the 3 or 4 cath labs and around the 24/7 the cardiologists are available there. So that is the reason we always send it for the primary PCA. A safe and effective alternative to the thrombolytic therapy. Rescue angioplasty undertaken in the patients who do not respond to the thrombolytic therapy. So PCA means percutaneous coronary intervention. PTCA, percutaneous transluminal coronary angioplasty, and CAPG. See the picture here, ABC. So the plaque, balloon, inflated balloon, that is a balloon angioplasty. In the second picture, you have the stenting. So the plaque, expanded the stent, inflating the balloon, and then the stent will be there in that particular occluded vessel. So one is the balloon angioplasty, the second one is the stenting or the PTCA. So this stenting is much more better and more useful than the balloon angioplasty. So this is your CABG. See the vessels there, connecting vessels, your internal mammary artery or the saphenous vein graft, arterial graft. Arterial grafts are much more better than the venous grafts. And with your CABG, So you can give the make the patient asymptomatic for a period of about 15 to 20 years. So after the 15 to 20 years, if the patient is not responding your medical management, suppose if the patient is not stopping the smoking, is not reducing the body weight, so you're not compelling with your drugs, and definitely these arteries also again block. So then you can go for the second bypass, a redo CABG. So very few people will be trained in this redo CABG or the second CABGs. And one of that fellow is Dr. Panda. Is a very famous cardiothoracic surgeon presently in Mumbai, Asian Heart Institute. So recently Kodal Nani shifted from Hyderabad to Mumbai for the redo CABG by Dr. Panda. He is the only doctor who has done this very high number of the second bypass in Indian populations. Have you heard of Manmohan Singh? Manmohan Singh. So ex Prime Minister. So the same Panda, he operated on Manmohan Singh. So as a Prime Minister of India, those people should not entertain to the private hospitals. So Panda from Mumbai, working in the private hospital, posted in AIMS, New Delhi, as a assistant professor of CT surgery in AIMS. So after he posted in the AIMS as an assistant professor, then the Manmohan Singh was admitted in AIMS and operated. And after the operation is over, then he has go back to Mumbai after resigning the AIMS faculty. Okay. So why I'm saying no? So this is a very difficult surgeries, redo bypass. But lot of people, our people, so after a CABG, so they thought that so everything is fine with my heart. So this is only bypass. Okay, that bypass area is also will be blocked. So many areas we have the bypass. In Kakinada we have the one bypass. In Petapuram we have the one bypass. Even in our Vizag also, that Anandapuram or something, Vijayawada you have the bypass. But after a few years, what will happen? Again, the people will there. Shops will be there. Again, that area also will be very crowded. And again, you may need another bypass. The same way here also. So after the 15 years or 20 years of the first bypass, so those people, they require the second bypass. Because in India, we are getting the early ischemic heart disease. So at the age of 30 years or 40 years, if the fellow is subjected for the CABG, he has to live for another 40 years. So average lifespan up to 80 years right now. So this is very difficult. So compliance with the drugs is very important. And then the control of your comorbidities is very important. So the management of your diabetes, management of your hypertension, management of your dyslipidemia, ideal body weight, cessation of the smoking. So these are very important to avoid the redo bypass or second bypass. What are the complications of the myocardial infarction? So arrhythmias, continuing ischemias, acute failures, pericarditis, or Dressler syndrome. Mechanical complications, papillary muscle damage, rupture of the interventricular septum, rupture of the ventricle, embolism, or impaired ventricular function remodeling, and the ventricular aneurysms. So these are all the complications of the myocardial infarction. So whenever you see any bad case of myocardial infarction, you should suspect these complications. So is there any arrhythmias are there, any circulatory failure, any pericarditis, or any mechanical complications, and the infarct is very high. So then with the papillary muscle damage, you may have the myocardial mitral regurgitation, rupture of the interventricular septum, rupture of the ventricle, embolism, impaired ventricular function, and the ventricular aneurysms. So the arrhythmias, pain relief, rest, reassurance, and the correction of the hypokalemia can all play a major role in the prevention of the arrhythmias. So the electrolyte balance is very important in the ICU patients. So nowadays we are seeing a lot of the hyponatremias and hypokalemias. Okay, these two you should know how to detect it, how to manage it. Common arrhythmias in the acute myocardial infarction: ventricular fibrillation, ventricular tachycardia, interventricular rhythm, ectopics, atrial fibrillation, atrial tachycardia, sinus bradycardia, particularly after inferior myocardial infarction, and heart blocks. So 5 to 10% of the patients who reach the hospital, they have the ventricular fibrillations. That is the major cause of the death in those who die before receiving the medical attention. So most probably they are dying of ventricular arrhythmias. So the prompt defibrillation is the answer to survive the patient. Atrial fibrillations are also very common, but frequently transient, may not require the treatment. If the arrhythmia causes a rapid ventricular rate with a severe hypotension or the circulatory collapse, then cardioversion by means of an immediate synchronized DC shock or digoxin or anticoagulation. So usually use the anticoagulation in atrial fibrillation population. Sometimes may use the digoxin also. Nowadays we are not using the digoxin very frequently in cardiology cases because it is not a mortality reduction drug. It only gives you a symptomatic relief, digoxin. Pericarditis is a very common on the second and the third days. You have the pericardial rub, Dressler syndrome, that is a post-myocardial infarction syndrome, persistent fever, pericarditis, and pleurisy. So the fever on the second or third day and pericardial rub or the pleural rub. So mostly the patient is in the Dressler syndrome. It's due to the autoimmunity, occur a few weeks or even months after the infarct and often subside after a few days. High dose aspirin, increase the aspirin, NSAIDs and steroids because of its autoimmunity. But rarely we see, but whenever the fellow is having the fever or pericardial rub or pleural rub on the second or third day, you suspect the Dressler syndrome, not a high mortality, but you have to give the increase the dose of the aspirin or the NSAIDs and then give steroid also. Papillary muscle damage is very common. A sudden onset of the severe MR, acute pulmonary edema, and the shock. Rupture of the interventricular septum, VSD. So in VSD, you will have a pansystolic murmur. In the same way, mitral regurgitation also can have a pansystolic murmur. So you are hearing the pansystolic murmur on the third or the fourth or the fifth day of post-MI. So definitely the patient is having either papillary muscle dysfunction or the interventricular septal rupture. So get the echo done. So that will clinch your diagnosis. Rupture of the ventricle, the cardiac tamponade. So this is the infarct expansion and ventricular remodeling. See the lower one. So that is the infarct. Infarct is expanded. So the increased wall stress above that. So the full thickness myocardial infarction causes thinning and stretching of the infarcted segment, which leads to increased wall stress with the progressive dilatation and hypertrophy of the remaining the ventricle. The late management, lifestyle modifications. So stop smoking is very, very important. Exercise is very important, and the diet is also very important. So as I told you, so less saturated fats, etc. Weight control and lipid lowering drugs. Secondary prevention drug therapies. Here the antiplatelet therapies, beta blockers, ACE inhibitors. Most important is the statins. Additional therapy for control of the diabetes and hypertension, provided if the patient is also having a diabetes and hypertension. So these drugs are very, very important. So your advice is stop smoking, good exercise, good diet, and then give aspirin, give the clopidogrel, give beta blocker like your metoprolol or your bisoprolol, then give ACE inhibitors like your ramipril, etc., and high dose of the statins, and then control if the patient is also diabetic and hypertensive. And finally, rehabilitation. What about the prognosis? In almost a quarter of all cases of the MI death occur within a few minutes without a medical care. Half the deaths from the MI occur within the 24 hours of the onset of the symptoms. And 40% of all affected patients die within the first month. Prognosis of those who survive to reach the hospital is much better, with a 28-day survival of more than 80%. Nowadays, the good survival is very, very good in the hands of the interventional cardiologists. Of those who survive an acute attack, more than 80% live for a further year, 75% for 5 years, 50% for 10 years, and 25% 20 years. But I think that a lot of people are living beyond 20 years. I think nearly 70% in India, they are living beyond the 20 years with your good PTCA or CABG management with your myocardial infarction. So early death is always due to the arrhythmias. Later on, the outcome is determined the extent of the myocardial damage. Unfavorable features are the poor left ventricular function. So that is your systolic function, EF, heart blocks, arrhythmias. So the prognosis is worse for an anterior infarct than the inferior infarcts. So anterior extends to anterior wall infarctions, and V1 to almost V5, V6, you will have the ST elevations and ST depressions, etc. In inferior, you have the L2, L3 and AVF. So the subset of the diabetes and ischemic heart disease is very common in our Indian population. So it's a major complication of the diabetes. So almost most common cause of death in diabetes is a myocardial infarction. 50% of the individuals with diabetes died due to the coronary artery disease. They share a common soil for the development of the disease, your environmental factors. CAD, which leads to premature MI, is the leading cause of the death among the people with the diabetes and result in threefold higher mortality than in those without the diabetes. So this is the very important slide, shows you two subsets of the people here. In the first one, patients without the diabetes. In the second group, they are the patients with diabetes. First group without the diabetes, no prior MI and the prior MI. See the green one, no diabetes but MI. So what is the risk? 19%, 19. And the second group, they are the diabetic individuals but no MI. What is the risk there? 20. If they also had an MI, 45. So which is one is higher, 19 or 20? 20 is high. What is 20? A simple diabetic but no MI. What is 19? No diabetes but MI. So that means MI is actually as equivalent as the presence of the diabetes itself. So that is the reason diabetes is considered as a myocardial infarction equivalent. These are all the factors underlying the accelerated atherosclerosis in diabetes. See the atherogenesis, atherosclerosis progression, and the thrombus. You all know these things. The lipid particles, okay, endothelial dysfunctions. Nitric oxide is a good vasodilator. Unfortunately, they're reducing the nitric oxide levels here. Increased free fatty acids, increased advanced glycation end products, increased PKC, increased polypoids, increased vascular inflammatory markers, oxidative stress. So these are all the different factors responsible for your atherosclerosis and thrombus formation. So in people with diabetes, CAD, even myocardial infarction could be silent. So the most common symptom in MI with myocardial diabetes mellitus is not the chest pain but breathlessness. So that is angina equivalent in diabetic individuals. What are the peculiarities? It may be silent. Atypical presentation, that is angina equivalence, occurs at an younger age group, maybe 25, 30, 40. We are seeing diabetes and IHD. May involve the small vessels selectively, the microvascular angina. Even if you get the CAG is normal, but still the patient is having the angina. So what is this angina? This is microvascular angina, not seen with your macrovascular coronary angiograms. There is a diffuse and the multiple vessel involvement. So that is the reason CAB is the answer for a diabetic ischemic heart disease, because the disease is very diffuse and also multiple vessels. Complications are very common, like your arrhythmias and heart failures, etc., blocks. Worse outcome following the revascularization procedures. Even after your PTC or CABG, the prognosis is not that good in a diabetic individuals when compared to the non-diabetic individuals. So the preclinical and the clinical. Preclinical, see the diagnosis with the biochemical markers like your homocysteine, lipids, lipoprotein little a, high sensitive CRP, fibrinogen levels. So these are all the risk factors, vascular risk factors. Endothelial dysfunction, intimal media thickness, etc. Whereas the clinically, you can have the troponins, CKMB, resting ECG, TMT, echo, stress thallium, angiogram, etc. So the major goals of the treatment: increase the coronary artery perfusion, decrease the myocardial workload, prevent the myocardial infarction, disability, or the death, and intervene in cases of unstable angina also. So SGLT inhibitors are very good. ACE inhibitors or ARBs are good. Finerenone, so that is the meningocorticoid receptor antagonists, they are also good. Steroid sparing, beta blockers. So in all the diabetics and ischemic heart disease, we prefer the beta blocker, we prefer the SGLT inhibitors, we prefer the GLP-1 receptor agonists, ACE or ARBs, and instead of the spironolactone, we prefer the finerenone. So secondary prevention, these are all the important drugs. So these are the strategies for the CAD risk reduction in patients with diabetes. 10-point formula. Early diagnosis, good control, control the lipids, control the BP, aspirin, dietary modification, good exercise, weight reduction, cessation of the smoking, and relaxation techniques. So this is the 10-point formula to reduce the vascular events in all the diabetic individuals. So thank you very much for your patient hearing.